Today we are having a topic on palliative care and non-cancerous illness. So we can start with Sir's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. By 4 o'clock, we can have our case presentation, followed by its discussion. By 4:30, we can wind up our session. Over to Dr. Sunil.
You take it. Just tell sister also not to send anyone inside. Not to send anyone inside. Yeah. Thank you.
Good afternoon, all. Dr. Pankaj, can you switch on your video?
Sorry. 1 second. Yeah.
Okay.
Hello.
Yeah. We can hear you. Can you hear us?
Yeah. Good afternoon, Dr. Sunil. Hi, everyone.
So today we are having an important session on non-cancer conditions which require palliative care. Dr. Pankaj will be speaking to us, who is the assistant professor in palliative medicine in the department in KMC Manipal. So welcome, Pankaj, and it's over to you.
Thank you, sir. Good afternoon, everyone. Today we will be discussing about palliative care in non-oncological diseases. Yeah, my screen, can you see now?
Yeah.
Yes, sir.
Yeah, it's in the full screen. Okay. So we will be discussing about palliative care in non-oncological illnesses. It's a very important topic. Like we usually talk about palliative care in cancers only, but nowadays the need for palliative care in other illnesses is also increasing, and people are get to know about when they need it. But unfortunately, in like healthcare settings, most of the doctors, physicians also don't know when to refer those patients and how we can help. So we will talk about a few things. So before starting, we'll go back to our basics, like what is palliative care. So as you see in the definition, it is care for patients with all serious health related sufferings due to severe illness. It's not only for the cancer, any severe illness, and the patients with severe illness or suffering may need palliative care, and its need may increase at the time of end of life. So this is the model of palliative care, where the palliative care or comfort focused care go along with the disease focused care that may be started from the diagnosis of such advanced illness, and its role increases at the time of the terminal life of the patients, and it goes beyond on the death of patients for the bereavement. In the whole the illness period, we provide a good symptom control, that's comfort care, along with the psychosocial and spiritual support for the patient. So what are the common illnesses whom palliative care may be integrated? So every system wise, if we go, so like respiratory diseases, we have advanced COPD, bronchial asthmas, there are patients with tuberculosis, MDR, TB, they have sequels of tuberculosis, and the patients with interstitial lung diseases, a lot of occupational lung diseases, and they have persistent breathlessness, persistent symptoms, and they have, and as the disease progresses, we require the symptoms increases, and the need for palliative care increases in those patients. Heart failure, those end stage heart failure patients may improve with some of the palliative care interventions. a huge need for the patients with end-stage renal diseases, those who are on dialysis, or those who doesn't want dialysis. They choose not to go for the dialysis. Those patients, and nowadays it is increasing a lot, especially in our country. And so those CKD5 or CKD5D patients, palliative care can be integrated. In neurological diseases, we see a lot of studies, lot of centers are doing palliative care in neurological diseases, especially for dementia patients with stroke or chronic stroke. A lot of traumatic diseases, we see patients with paraplegia. They have a huge requirement for palliative care. Infective disease. So when palliative care was started, it was started for the cancer and HIV, because that time there was not a good treatment for HIV. But even now, with the availability of good HARTs, patients are living for a long life. Maybe their life expectancy may be near normal, but they have a lot of symptoms. They have a lot of psychosocial issues. Yeah, still there is a lot of need for palliative care in such patients also. MDR or XDR tuberculosis, the sequels of tuberculosis, they get more breathlessness, and they have a lot of stigmas related to that. Or many times in patients who are having life-threatening infections, they are in sepsis, they are in ICUs for a long time, and that is going into multi-organ and dysfunctions. For a good terminal care also, in such conditions also, palliative care can be integrated. Here in our hospital, we have also started palliative care in ICU patients. So maybe who are in ICU for long term, and the ICU physician or the primary care physician feels that continuing long-term care or long-term ICU care is becoming futile, and then we discuss those things with the family members, among the physicians, and we may facilitate some of the important decision in such conditions. So and in the literature also, we see a few articles in the ICU palliative care and palliative care in the emergency departments. So because most of the patients at the presentation of their terminal illness, they come to emergency department, and if we can triage some those patients in the emergency department only, or those patients who are already ill and when they are coming to the emergency department, how we can try such patients, or how we can involve directly the palliative care team in the AD or casualty only. That is important. So in like next 30 minutes, we will talk a bit about a few diseases in detail, and then during the discussion we can talk more, we can have questions, and then we can talk more how in your settings we can evolve the non-cancer palliative care. Okay, so what is the difference between palliative care in cancer and I think most of you must be aware of palliative care in cancer, but how does it different from palliative care in non-oncological illness? So you can see the red line. This is for disease trajectory of cancer. So usually the cancer patients, when it is not advanced, and they have near normal life, they have good performance status, but suddenly as their illness advances, they have a very rapid deterioration of their quality of life or their functionality. But it is not same in many of the non-oncological illness. So like if you see the patients with COPD or patients with heart failure, and they may have a good quality of life, but as their disease progress or as their age advances, they will have in between some dips that may be because of acute exacerbation of COPD, or maybe because of the infection, or in CKD patients like they have some failures, and their quality of life suddenly deteriorates, and with the treatment it may improve also, but they do not get the pre-morbid state again, and there is gradual deterioration in their functionality. But and such episodes may repeat every time. The third green line that you can see is in the patients with old age, frail patients, or patients in dementia. From the beginning, they have a poor quality, and they have more or less functionality. And with the time, that progress or that worsens with the time. So this diagram, if you can see, it helps us to identify when can we integrate palliative care. So usually at the time of such exacerbation, we can involve the palliative care at the time of exacerbations. Maybe simple counseling or good psychosocial support at the time of such exacerbations. And slowly, as their progress increase, the role of palliative care can increase. Uh, in patients with CKD also who are not on dialysis, their trajectory is also like the cancer only. They may have a good functionality for some time, but if they are not in dialysis, they can also have a sudden fall in their functionality. Uh, and there are some studies which can helps us to identify when can we consider a patients for palliative care in non-oncological diseases. In cancer, it is very easy, like patients with stage 4 or whom a cure is not possible, they refer to palliative care. Yeah, with the palliative chemotherapy or palliative disease modifying treatment. But it is very difficult in non-oncological cases. So there are some of the criteria here that you can see. Recently, there's a gold standard framework that helped us to identify such patients. So here you can see, and there are 3 steps. So first step is to ask the surprise question. Here we ask the doctor that would you be surprised if the patients were to die in the next year, months or weeks, usually last like next 6 months or next 12 months. So if the doctor says, the primary care physician says, no, I won't be surprised, then we can begin the gold standard framework. Gold standard framework is to identify those patients who may be in the last year of their life, to assess their needs, the physical needs and their personal, that is psychosocial needs, and to plan. So that may be for good quality of life, and to provide better quality end of life care also. In those patients whom physician is not sure whether such patients, that patients may have limited lifespan, then we can use the general indicators. So general indicators here, if you can see, this is for all the illnesses. So they have increased dependence or increased need for the support, repeated unplanned hospital admissions, advanced disease that is unstable or deteriorating, or that has complex symptoms burden, presence of significant comorbidities, and that many comorbidities, decreasing activity. So we can, if the patient's performance status is continuously declining, or patient is most of the time they are on the bed, or their dependence has increased, then we can say that this patient has decreasing activity, decreasing response to the treatment, or the reversibility of the disease is decreasing. At any point of time, the patients choose that they don't want any further active treatment, and they want to focus only on the quality of life. So these are some of the criteria, like some progressive weight loss or some sentinel events. Serum albumin is less than 2.5 gram per deciliter is also an indicator for less than poor prognostic index. So according to GSF PIG, if any patient has having more than two or more than two general indicators, he may be a candidate for integrated palliative care. Then if we go back to the previous slides, so if with general indicator, if we feel that patient is means we can start palliative care in these patients. If in with the general indicator also we don't know whether that patient is eligible for palliative care or not, then we go for the disease specific criteria. So there are criteria for organ failure, and there are some criteria for frailty or comorbidities. So if you can see, there are criteria for heart diseases, there are criteria for COPD, and criteria for renal diseases, CKD, liver diseases, general neurological diseases, Parkinson disease, motor neuron disease, multiple sclerosis. So these are all for the organ failure, different organ failure. You can see this, these, GSF PIG on the Google only. You can get this document, and I think you all should read about this document. It's only 3-4 page document, and it will give you a good idea of those patients whom palliative care can be involved. Some other criteria like in the frailty, dementia, and stroke. And these patients are having more comorbidities or poor function. And there are some other identifications tools also, like SPECT LIS, that is for the low income settings, that we can use in our country. That is a single page document, and that also has a general indicators and disease specific indicators. More simpler form of that aspect is there. So that also you can use to identify such patients. So if we go for the palliative care in India, we can see like the most of the palliative care centers are only for cancers. Not means very few centers are offering palliative care in non-oncological diseases, and we have only 3 centers who are providing MD courses, and all of them are only in the cancer institutes also. So and there are huge need and huge gap in palliative care delivery for non-cancer illness. So then we will go for renal palliative care. So if you see, there is increased number of population in India who are with CKD because of multiple comorbidities, and it is among a leading cause of death also. If you can see, in 1990s it was beyond 20 in the leading causes of death, but recently it is in the top 10 causes of death on the CKD is. So a lot of patients are dying with CKD. They are on dialysis, and if you see the survival 5-year survival rate, it comes in between 40 to 60%, and that is among the among the worst type of cancers also. So those patients also require a lot of support from palliative care. How does patients with kidney disease got treated? So like if a patients have some risk factor for CKD, we go for to prevent the CKD. Um, if there is patient has diagnosed with CKD, then we try to slow the progression or prevent the complications. But if a patient is with end stage CKD, then the treatment options are like the dialysis, transplant, or the patient may also have the option of comprehensive conservative care. Means the patient can choose whether they want dialysis or not, or if they are not choosing for the dialysis, they can choose for comprehensive conservative care. We will talk about this thing. Even those patients who are on dialysis or who underwent transplant, they may also be a candidate for comprehensive conservative care, or in other word, renal palliative care. There was a study by Carson et al. In that they saw that those patients who were on the dialysis in the dialysis cohort, they have seen that most of those patients who survived longer, they spent most of their time either on the dialysis or they were hospitalized because of the complications of the dialysis. So that doesn't mean that always the dialysis will add the meaningful days to their life. And there can be option of conservative care also. There's another study where they have seen that in SF36, that is a quality of life domain, they have seen in both group there were no improvement over the time, but in the supportive care group, the bodily pain or general health perception or vitality, that didn't deteriorate, while in the dialysis group it deteriorated. And also they have a better mental health status also. For any there are 4 pillars of palliative care approach in any diseases. So first and foremost, the good communication, symptom management, and psychosocial support, and end of life care. So for in the communication in CKD, that's very important. If we are dealing with one patient who is who chose for the conservative care, or whom the nephrologist feel that may not that patient is not benefiting with the dialysis. So communication is the key. Here we have started in Manipal, we have started the renal supportive care clinic. The common problem that we face, like someone else is saying that the dialysis is the only option. If you don't get dialysis, means you will not receive any medical care, and they feel abandoned in such things. Even nowadays, we see a lot of patients who are having multi-organ dysfunctions. They are actually dying, and they also receive dialysis in their last 2 days of their life. They are on the life support system. Symptoms, if you see, and this is a study we did to see the palliative care outcomes in some of the patients who are on dialysis. So we found that these patients had a lot of symptoms, like 30% of the patients had mild pain, and moderate to severe pain there was in around 20% of the patients. Around 2/3 patients had fatigue. Half of the patients have lack of appetite. lot of them have restless leg. So a numbers of symptoms they have, those patients, and with the palliative care approach we can decrease the symptoms. uh, and there is a lot of psychosocial needs also, and there was a communication gap. They have a huge financial and practical needs, and those patients, again in our study also, the 80% of the patients felt that they were wasting significant amount of time in healthcare facilities, or they are spending most of their time in hospitals. uh, if you want to read more about CKD palliative care or renal palliative care, I will suggest this document to read once. That is Cadigo's guidelines for renal supportive care. It has given on the all the physical symptoms, how to approach for such patients, what are the guidelines to withdraw from the from the dialysis. If they do not want to initiate the dialysis, what are the guidelines? What does renal supportive care means? So this is the one document I would suggest you to read for CKD patients. So here you can see for each symptoms they have given the evidence-based practice for each symptoms. These are for how should we assess those symptoms and management recommendations. How can we estimate the prognosis, and what are the recommendations for those patients in CKD patients. In 2010, there was also one guideline for the appropriate initiation and withdrawal from the dialysis. That is also very important when we are making such a decision. So what they say, like it should be shared decision making. The doctor should should have a communication, and patients or their decision maker should take shared decision making. So these are some of the guidelines for consideration of the dialysis withdrawal. So first, we can identify those patients who who may benefit from the withdrawal, or who are having very limited estimated prognosis. Those who are having poor quality of life, or those who are having severe pain that is not responding to treatment. Those patients who are also having progressive untreatable diseases, some other diseases than the CKD. They are unable or unwilling to tolerate further dialysis, or dialysis is not feasible, maybe because of financial reason, maybe because of the logistic reason. So in such patients, we discuss about their goals, what the patient knows, what the patient's family members wanted to know, and discuss about the option of the better quality of life, the possible palliation of the symptoms. And then we clarify whether the withdrawal from the dialysis, whether it's an option or not. And very important that we have to reassure that that the patients may have a peaceful life, or peaceful end of lifetime. We have to give time for the discussion among the family members, because such patients may be on dialysis since many years, and it may be difficult for them to choose not to go for the dialysis. So we have to give adequate time, and they may need multiple family meetings. We go for pain in CKD patients. Most of the time, physicians are worried that that patient is already having a kidney disease, and they are worried not to use for the pain medications. So there is a step ladder for CKD patients. So like for mild pain, most of the NSAIDs are contraindicators. So, but we can use paracetamol up to 3 to 4 gram per day. For step 2, we can use low dose weak opioids like tramadol, tapentadol can be used, but usually avoided. But if a patient is on dialysis, it means tramadol can be used up to 100 mg per day. Easily it can be used. For severe pain, or if we want to choose the strong opioids, the fentanyl is the safest choice. Other than buprenorphine can also be used in the patients with CKD. Uh, uh, but if a patient is having like a anuric, or their all the kidney functions are not there, sometimes it is justified to 1 second. Okay, justified to use NSAIDs also if the patient is having severe pain and no other strong opioids are available. NSAIDs in such patients can also be used. If like fentanyl is not available, morphine can be used in few patients, but we have to decrease the doses, and that is only when other options are not available. Okay, so that was about the renal palliative care. In short, we will go about palliative care in HIV and AIDS. So, when do we call it as a terminal illness in HIV? So, usually some of the criteria that some of the studies have suggested are like CD4 counts very, very low, or viral loads very, very high, with some maybe disease like HIV related disease like CNS lymphoma, wasting, or infection, multiple infections. So some of the complications that may be supported by some of the criteria like albumin less than 2.5, those who are not using ARTs, or organ dysfunctions are there. There are like these are the approaches for palliative care in HIV. So one is clinical care for asymptomatic patients. Their clinical monitoring, providing the other help. For the symptomatic clinical care, maybe for the pain control, breathing, fatigue, those are the main symptoms. So palliation of such symptoms, and end of life care in those patients. Other domains are psychological, spiritual, or social care. So we'll go for some of the symptoms like the and there may be some causes like this is for the fatigue. If we see there are causes for fatigue, it may be because of infections, maybe because of anemia, hypogonadism, wasting, or depression, or it may be idiopathic also. So we will continue the specific treatment like ARTs or treating the infections. With that, the palliative approach can also be used. So like using psychostimulants for the short term, or using corticosteroids for the short terms. This is for like weight loss or anorexia. So if it is associated with hypogonadism, that is very common in HIV. Testosterone can be used, magistrol acetate, and that is anabolic steroids can be used in some patients. If the patients has like sometimes recombinant human growth hormones can also improve their body weight also. So these approaches can be used. Pain again in HIV is very common. That may be because of the infections, maybe because of the treatment, or their debilitating conditions. They usually have a very severe polyneuropathies, maybe because of any reasons. And so again, those gabapentinoids or TCAs can be used in such conditions. There are some barriers for palliative care in HIV or pain management. So because most of the time the physician doesn't know how to manage those pain, there are reluctance to use opioids because they feel those patients may be already drug addicted, or like they are on many drugs and there may be drug interactions. So those are the common barriers. So there are polypharmacy that can cause drug interactions. So like many of the medicines that are cytochrome P450 inhibitors, both in the those who are which are used in the palliative care settings and those HIV ART medications. Some may be inducers also, and these are the common drugs that is used, like opioids are metabolized through CYP450. Benzodiazepines, antihistaminics, those drugs are the substrate for CYP450, and these can cause potential drug interactions. So in the patients with HIV, we have to be a bit careful when we are choosing the drugs. And then this comes for the dyspnea. Like dyspnea can be because of infections or anemia. So again, a disease-specific treatment in such conditions, and using the palliative approaches also, like using the opioids or using a handheld fan. Those things can be used to decrease the dyspnea. And there's a lot of debate, like in cancer, we know when to stop the chemotherapy or disease modifying treatment, but in HIV there is no such recommendations. Most of the guidelines is to continue if a patient those HART, if a patient is not having any difficulty. But if there is a problem with patient's adherence, or patients feel that the pill burden or financial toxicity is there, then we may consider to stop ARTs if patient is toward the end of life. Only in such conditions. Otherwise, it is recommended to continue HART. So, sorry. And then we are coming to, there's some disturbance in the slides. Okay. So palliative care in neurological illness. So what are the common neurological illness that in which palliative care can be involved? Such diseases which have the short onset and limited life expectancies. So like we see a lot of patients who are coming with traumatic brain injury, maybe road traffic accident, or they have asphyxia, later ischemic brain injury, severe stroke, who are comatose for a long time, or those who are with very aggressive neoplasm like GBMs. Or there may be the disease which are progressive disease, and that has long duration, that has, and they progress and degenerate. Neurological diseases are there, like advanced dementia, neuromuscular diseases, motor neuron diseases, advanced Parkinson disease, Parkinson plus disorders, multiple sclerosis, patients with movement disorders. So these all are the diseases where palliative care can be involved. And we have seen such patients it helps, the palliative care helps in their rehabilitations or improving quality of life. I have heard a lot of good things that is going in the Pallium. They provide a very good support to those patients with paraplegia or with the stroke. I have seen in IPM also such rehabilitations. what are common issues in those neurological diseases? So, as other diseases, such patients also have pain. It may be the central pain syndrome, post-stroke pain. Pain may be because of the debilitating or maybe because of the strictures. They find very difficult to move because and they are most of the time on the bed. There may be cognitive impairments, sensory deficits, and they are on the beds that may lead to the bed sores and all, and the problems in respiration or in the drooling of the saliva, rigidity. Those all physical symptoms patients may have. But on the top of that, they have a lot of psychosocial things also, because they are not able to communicate. They may not tell you the symptoms, or they are distressed. They are not able to communicate with the family members, with the friends, and that leads to social isolations. If they don't have a good rehabilitation support, they end up with the chronic disabilities. And a family also, because these diseases usually go for months, years together, and that may also lead to the family in distress and caregiving issues also. The impact of such neurological diseases are like increased mortality, maybe because of the infections, aspirations, thromboembolic phenomena. There are more of the behavioral complications, safety issues, especially in the dementia patients. There is loss of identity, and there's a lot of dependence on others, and that's why caregiver also feel more anxious and depressed, and they have distress issues and goal of care. I think I have to stop here. Mm, I will have 5 minutes more. Can I continue?
Yes.
Okay, thank you. So, okay, some core elements in such neurological conditions are like we have to assess thoroughly such patients. Wherever possible, we have to control the disease progression and prevent the complications, like in the seizures or in the patients with Parkinson and disorders. So, we need to halt the disease progressions. Management of such symptoms very aggressively, so we have to evaluate them for the depression or pain. Provision of the physiotherapies to prevent the spasticity, to prevent the bed sores and all. Very important, we have to provide the aids, maybe for the walk or maybe for the activity of daily living. So a big role of occupational therapies. Some practical coordination and the support, maybe involving the volunteers or social workers in such conditions, providing good psychosocial spiritual support and good end of life care. This is again one of the consensus document that was given by Dr. Oliver. It came in the EAPC in 2016, and that is also a good thing to read for palliative care in neurological diseases. COPD, I think we may discuss in respiratory symptoms also. So when do we call it end stage COPD? When FEV1 is less than 30% of the predicted, or when they have very limited performance status. Other criteria are like advanced age, presence of multiple comorbidities, or severe systemic manifestations also, and that is because of COPD. So that is the criteria for calling it end stage COPD. This is again that same the gold standard framework that we discussed before. So any of those two criteria, if it is there, that can be considered for palliative care in such patients. The approach is like this is given by the gold criteria. So whenever possible, we have to start with bronchodilators, systemic or inhaled steroids, other bronchodilators, maybe long-term oxygen therapy if patient is proxemic, or if the patient is benefiting from the oxygen, can be started. But if a patient is not improving with those pharmacological therapies, uh, we have to involve the non-pharmacological therapies also, so like exercise training, pursed lip breathing, using the walking aids, or decreasing the energy, adjustable vibrations and all. And if with that also, if the breathlessness is not reduced, then starting and the opioids also. So especially the morphine, it has been found that morphine works quite well for the patients who are having refractory breathlessness in COPD. So recently we had this Sunday only we had a master class on patient on respiratory palliative care. So there, the invited speaker David Kuro, he was telling about the research of some of the other treatments like bupropion has been used, the fentanyl lozenges has been used. So there are good research coming up with for the breathlessness in COPD. The thing in COPD, the requirement of opioids may be very, very less, and that may be much lesser than what is used for the pain. So this was about the palliative care in the non-oncological diseases. So before I stop, I have few questions for you. This is especially in non-oncological diseases. How can I use my professional skills or knowledge to reduce suffering? How can I become passionate presence to someone who is suffering? And what am I learning about myself when I listen to someone who is suffering? And this is very important in those patients who are having incurable illness, especially the non-cancer illnesses. Okay, thank you so much.
Thank you, Dr. Pankaj. So that was more on broad aspects of non-cancer palliative care. And if you want to ask anything specifically on any subjects, then all of us can try to answer that question. Dr. Narendra.
Thank you very much for presenting about all the illnesses. But can you specifically say at what time that you need to invite the palliative care physician into these respective fields?
Yeah, so as I said, that means that is very difficult. So there are frameworks like gold standard frameworks. If you see those like 2 general criterias or 1 general criteria along with 1 disease specific criterias that are fulfilling, in such conditions we can involve the palliative care. If we go the disease wise, like if the patient like a primary care physician feels that the patient's disease is progressing and he is more dependent, their performance status is deteriorating continuously despite the treatment, that would be a better time to involve the palliative care team in non-oncological diseases.
So, Dr. Narendra, so as per diseases, there are some criteria which some bodies have come up with, and Dr. Pankaj is speaking about the gold standard framework, in which the physician or the team asks, will I be surprised if this patient lives for the next 1 year? So if the patient, if the team thinks that this patient is, or if somebody answers that, okay, we are not, we see that this patient is not going to live for another year, then that patient is qualified for palliative care. That is what the gold standard framework says.
Dr. Narendra, you have another question, sir? Yes, sir. Yes, sir. Yes, Dr. B.S.R. Murthy, you can speak, sir.
Overall, we have 3 graphs doctor has shown me. The first and second, the first and third. Once we start, it is up to the end of the life. In the cancer patients or chronic disease patients, once we start pallium, so slowly dose may come down, dose may be adjusted, it will have to be continued into the end of life. The middle graph, you have the green graph, episodes only will be needed. And decision of the patient's terminal stage, it can be decided whether it will continue or not to continue. It's a question which does not directly deal with us, but all over India, there should be a sort of a standard in how long they can keep in ICU units. Keeping in ICU units for months together is a drainage of the national exchequer, it drains the pockets of the patients, and the patients' families are getting ruined because of this continuity. So for that, something like after 1 week of ICU care, they should have a step down. For example, ICU is given. If they get discharged, they will need oxygen, maybe 8, maybe 6, maybe 5 liters. But if you have to continue, revive the patient and send home, we'll have to find out they can survive without oxygen. For that, after 1 week or 2 weeks, step down the ICU oxygenation and find out. So like great national money is extra money is being wasted in continuously keeping months together in ICU. Whether they can get good results or not, we do not.
Yeah. And so, yeah, that's definitely most debated topic, like withdrawal from the life-sustaining treatment. So, but it is like very difficult to decide as a clinician, because many fears the legal issues and all, and there are no proper guidelines. Recently, there is like a ICMR document that has come, shows some light on that. But as we have in our hospital, we have like a Blue Maple policy where we decide whether continuing those treatment, whether it is futile or not. So if the physician feels that such interventions are futile, then we communicate it with the family members. If there is consensus in the family members and also in the treating team, then we may opt to decreasing the supports or going for the end of life care or whatever needed for the patient. Sorry, you are mute, sir.
Sir, can you unmute and speak, sir? We can't hear you. Yes, sir.
As per my personal experience, we run a Alliance Cancer Hospital since 1994. We have ethics committee, we have a parents committee, The ethics committee and parents committee will sit together and find out and discuss whether we should continue, depending on the progress of the individual in the cancer hospital, to continue on the life supporting treatment for a long time.
Okay. Thank you, sir. Dr. Bini says, do you want that policy, Dr. Bini? That's what you.
Dr.
Dr.
Bini?
Yeah, no, I was saying that was an elaborate presentation which Dr. Pankaj gave us. We would like to have the presentation so that we can go through it, taking more time. So
Yeah. All the presentations that faculty is being presented in echo sessions will be sent to you.
Okay, thank you.
And also, I would suggest such of those guidelines that I told that, like CADIGO guidelines, those consensus documents, they have given me in the 35 minutes. I couldn't tell everything, but those guidelines are very concise, and you can read at least for those CKD and neurological diseases. May help.
Dr. Veena?
This was, as Dr. Binijat said, a very elaborate presentation. I felt like chasing a plane, riding a bullock cart. So I really am far much behind. But to make it very, very simple, Dr. Pankaj, can we arrive at a collaborative multi-system indications for this palliative care? Now there is one COPD, the dementia, and I do feel that there are lot millions of people at home, not in the hospital, not in ICU, who need this care. At least we can educate the caregivers, that is the family members. Can we have a simple, straightforward palliative care workup for these patients of multiple system involvements or various other system involvements? Thank you. I don't know whether I'm clear.
Thank you so much, ma'am, for the compliment. And that is true that many a times we see only a disease or only a organ and don't see the people, the person as a whole. And I have gone through the GSF one, but the SPICT, if you see, like SPICT gives again like a general indicator, and there that involves the multi-system for the lungs or all. But even in that criteria also, there is a bottom line that if a physician feels or if a patient demands for palliative care, that will be a criteria that this patient should receive palliative care. It's not only with these indicators also.
Thank you.
So we see a lot of non-cancer patients, and many of these patients may not meet many criteria, and so palliative care which we provide as need-based. So if somebody asks and they need palliative care, and if the goals of care can be the same, if they expect something and if we can provide that, then we provide palliative care in non-cancer patients. So about 50% of our patients are having cancer, and the rest 50% are having non-cancer. Dr. Shashigala?
Dr. Shashigala, can you hear us, ma'am? Ma'am, can you unmute from your end and speak? Yes, doctor.
I think. No, anybody else want to ask anything?
Sir, can we get the palliative care masterclass PDF?
Dr. Pankaj, we can't hear
Please
you, sir.
unmute him. Please unmute him.
Yes.
Okay. Which master class you want? I have for renal, I have for neurology, and I have for respiratory, but cardiology, because it was done in Bangalore. So I can share it with Dr. Sunil, and that can be shared. Yeah, those PDF can be shared.
Oh, okay, sir. Okay. Thank you, sir. Thank you. Thank you, sir.
Thank you. Dr. Srividya?
Yes, sir. So when we were talking about that golden framework and that question, no, sir, will you be surprised? I mean, if the patient will live for 6 months or 1 year. So when we take that question into consideration, it only matters on the quantity of life, no, sir. Where is the question about quality of life? So how do we take a decision based on that, sir? Because most of the time we want, like if you take a CKD patient who's on dialysis, maybe as long as he's undergoing dialysis, his life nobody can predict, no, sir. He will survive. So whatever is worst case scenario, he's going to survive after dialysis. So when it take that into account, how is it, sir?
So if you see in the GSF, if someone is telling he will not be surprised, that means life expectancy is less than 1 year. That doesn't mean that if he says yes, that I will be surprised. That doesn't mean that it will means he is not eligible for palliative care. So those other indicators are for the morbidities. These are just indicators, means the most of the indicators, but there may be some conditions where the patient's quality of life or patients is having more symptoms, and palliative care can be involved in such conditions. And the maybe only the patient is having pain, and that may be the reason for involving palliative care. And as his disease advances, more palliative care interventions can be given.
Dr. Srividya,
Thank
you
you,
asked
sir.
a
Yes.
relevant question. And
Yes, sir.
if you look at the WHO definition, it says palliative care should be provided for patients with life-threatening, or sometimes it says it is life-limiting. Yeah? So life-threatening or life-limiting, you need to look at this life-threatening or life-limiting from another point of view. It is not from the point that the duration for which the patient can live. Suppose a patient who is paraplegic or quadriplegic, they are unable to live a life like other people. So their life is limited. If they can enjoy the life, then their life is normal. Otherwise, their life is limited. So in that definition also we can or we have the provision, if there are patients who has reduced quality of life, then they need to provide palliative care.
Thank you, sir. Thank you.
Dr. Veena?
I have just one question. Age-related, this Alzheimer's and senile dementia, Parkinson's, these things, is there a definite indication? And a little comment on assisted living, does it come under palliative care? Thank you.
Doctor, can you unmute from your end, Dr. Pankaj?
Pankaj, please unmute yourself.
Yeah, definitely those patients who are needing aids for assistance for those diseases like senile dementia or age-related dementia, they needs palliative care, means. But wherever we are talking about the needs for palliative care or how much needs are there, it depends on how severe the dementia is. So again, if it is a senile dementia, how much needs are there, and if they are having more needs, definitely the requirements will be more, the more palliative care interventions can be given.
So, Dr. Veena, I think rather than looking up specific points for in this condition for providing palliative care, what we can do is, if they want palliative care and if we can provide what they want, we should be able to provide the palliative care which they want. It should be need based rather than we are looking at certain points for providing palliative care. So we can move on to the patient story, which will be presented by Dr. Hema Saxena, who is the professor of anesthesia at Government Doon Medical College. Madam.
Yes. Hello, everybody. I hope you can hear me.
Yes, ma'am, we can.
Issues on connectivity. Can you hear me?
Yes, ma'am, we can hear you.
Good afternoon, everybody. So I'm presenting a case today of a female, 45-year-old, who was diagnosed as a case of subacute subdural hematoma with midline shift and operated. And she was a follow-up case of mitral valve replacement as well. And now she's in near vegetative state for almost a month. This patient presented to the hospital with loss of consciousness and probably with a doubtful history of fall at home. And she was left by the relatives in the hospital emergency with her medical record file by the side. So what a history of illness was gathered was assessed from the file which was left at the bedside. And this had multiple sets of documents from almost all the corporate hospitals of Dehradun. And we gathered that she was a follow-up case of mitral valve disease since 2008. And she had a mitral valve replacement done at Delhi Heart Lung Institute in 2011 with monetary help from her treating cardiologist only, from the local cardiologist in Mussoorie. And she had some follow-up notes in between off and on, but otherwise everything okay. But from November 2018, she had some documents of admission in Fortis Hospital of Dehradun with presenting signs and symptoms of cardiac breathlessness and difficulty and some swelling. And then she was admitted and discharged after 7 days. And we could see the discharge slip showing acetrom, ecosprin, and digoxin. Then in May 2019, she reported to AIMS Rishikesh with headache. But then there was a note that patient has left Lama. It was an OPD paper and patient had left Lama. Then in June 2019, she reported to another private medical college of Dehradun, CRR. And there she landed up in emergency with hematemesis, bleeding PR, and disorientation. Then on investigation, her INR was found to be 6.6. Acetrom was stopped, and all other investigations were practically normal. Her echo was done, which showed an ejection fraction of 50% with moderate AR. She was managed and discharged on Trenexa and antacids, pantoprazole, nutritional supplements, and follow-up visit after 10 days. Hello?
Doctor, we can hear you.
Yeah. Then she was again admitted to the same hospital in October 2019 with altered sensorium. And a CT was done. We could not find the details, but we saw that acetrom, ecosprin, and digoxin was restarted. Then she had some follow-up notes, follow-up OPD slips for her private clinic, which showed that she's presented with menorrhagia, and the person had gotten INR done, and which was 4.5, and referred her to physician. Then she landed up in Himalayan Institute, Jolly Grant, another private medical college, in the neuro department in last week of 2019 with altered sensorium after having a convulsion. Then she was diagnosed as chronic subdural hematoma and advised surgery. After that, she was found abandoned in the emergency of our Government Doon Medical College. She was admitted by husband and son, who did not return after the formalities of admission. And there was no way to find out what medications she had been, when she had stopped all medication and since when she had landed up in this situation. Then on examination, she had a low general condition. Her Glasgow Coma Scale was E2 M3 V2 and pulse was 72 per minute with a BP of 130/90. JVP and all was not raised. She had shallow respiration with low respiratory rate. On auscultation, chest revealed some few conducted sounds, but nothing much. An urgent CT was done, which revealed a subdural hematoma with midline shift, and other biochemical investigations were acceptable, including INR. And she was diagnosed as subacute subdural with midline shift and planned for urgent hematoma evacuation and burr hole under GA. And I happened to be the anesthetist at that time also. And we had the issue of consent, and the consent was taken by forming a board, and her surgery was uneventful. Post-op was fairly uneventful, except for episode of ventricular tachycardia and CHF on third post-op day. This was managed successfully. She improved gradually in 12 days to the extent now that she's opening eyes and swallowing semi-solids and liquids. And she seems to understand, expresses pain on injections, and then she had ptosis of the right eye with no bladder or bowel awareness, and hence she's catheterized and she's on diapers. Now she's on Dilantin, Ecosprin, and Ranitidine. She's being nursed in the ward, and as per neurosurgeon, she's unlikely to be getting any better. So the psychosocial aspects that we faced here were that she had been abandoned by the husband and son, I guess due to recurring medical costs in the last 2 years, and life-saving surgery had to be performed, as I said, by constituting a board of 4 doctors with medical superintendent to give the consent, because there was nobody, and the neurosurgeon said that I can't see her just going down and with the midline shift. And he was hopeful that probably she will come back to an extent that she'll be following commands and probably much better, that family will come back. Then now the hospital is planning to hand her over to the police as an abandoned patient, because there's they don't know, the ICU bed was blocked for quite some time. Now she's in the ward, and nurses are taking care of her with the hygiene. Some local NGO members have started visiting her. They with a juice and some toffees and chocolates in the evening, and they do some prayers for her, and they try to include her in the prayer, but she just vaguely understands. Otherwise, she is not reacting much. So next, now the main issue is that who will care for her and for how long. So now to summarize, I just want to say there's 45-year-old female, which is a follow-up case of mitral valve replacement with irregular follow-up in different hospitals, which led to chronic to subacute subdural hematoma, hematemesis, and finally a near vegetative state after the life-saving surgery. And now she requires nursing care as long as she lives, and there's no family to support. The points to discuss, I feel, are that how far we can go in the treatment of destitutes in such situations. And could we have prevented the scenario of her getting abandoned by the family? Maybe it was poor communication regarding her lifelong follow-up of mitral valve replacement and acid trauma management. And hospital and doctor hopping, of course, I think were the ultimate culprit for this situation. And moreover, like we saw some of her bills also, where the hospitals had done an endoscopy for hematemesis, and colonoscopy for bleeding PR, at least 3-4 ultrasounds, a CT chest and whatnot. I mean, a lot of things had been done. So she landed up with a financial mess also, the family. So so I think that is all. It's a very small this thing. The issue is that, like, I mean, it is open to the house that what was done. Now she's in a total vegetative state. She's being nursed, and what we can do for her further and how long is a question mark. Her other systems are normal. Her other biochemical issues, there is no problem at all. So if we go on to the discussion points, I mean, as I said, how far can we go in the treatment of destitutes? Our hospital resources are already limited. We did our best trying to get all the medicines arranged and whatever, but for how long? Then the money that has been spent on her previous treatment in the last 2 years is almost amounting to 80,000 to 1 lakh, which I think family has been drained after that, with enough CTs, ECGs, ecos, endoscopy, and whatever. And now we have a patient who, with the hospital and Dr. Hopping, she's landed up in a situation with no one next to her, and she seems to understand. So I feel we can't even leave her like that. And I strongly feel that it was probably the poor communication which has led to this situation. And if somebody had told her that acetrom, like she's on a drug for which she should be getting an INR done regularly, so there would have been, probably she would have been, better off that she would have got an INR done regularly. And if it was more than something, probably she would have done something, and the family would have been, saved from the consequences. So that's all I have to say. Thank you.
Thank you, madam. So we have a 44-year-old female patient who has undergone mitral valve replacement with regular follow-ups and has come up with many complications, and this time with subdural hematoma. And patient is in a nearly vegetative state, and the family left her in the hospital. So I think some of you might be familiar with the situation and how you have managed. Dr. Narendra, I can see he is nodding.
Ma'am, thank you, sir. Actually, this is a small case presentation with very big problem. First of all, the patient was not a regular. She has shifted to many hospitals without sticking to a proper medication. She must have not known the complications of azithromycin. Second most thing here, how far can we go in the treatment of destitutes? Here, sitting beside me is Dr. B.S.R. Murthy, is the president of Prama Samajo. We have around 60 destitutes who are with us in our own old age home. He is the chairman of the thing that we take care of all the things. We take it from the police, we register with the police, and then we take care of the thing, even though she is paraplegic or anything like that. I think the only an NGO can only take care of this kind of patients, because there is a lot of burden and the family has rejected her completely. So she was abandoned. So here what we do is we take up, and after taking up, if sometime untimely death has happens, we usually give the body after informing the police to the nearby medical colleges. Until that last breath, we usually take care. That is one thing. I think continuing with Decitram without knowing the complications means she must not have taken proper instructions or followed the proper instructions that would have been given by her. Because she was being shifted to various medical colleges and landing up in different setups. Abandoning is main because they must have not felt that there is no more use by her, and she is depriving them of their financial issues. That is what I feel, sir. And the doctors are not responsible for the outcome. Here it is only the family that could not be counseled before of the outcome. That is what I think.
Yes, Dr. Murthy.
since the addresses are there, you take the help of police, we can trace out the families and their addresses. Even if the addresses they are not available, how can a hospital bear this cost, this much of cost of treatment and all that, sparing a bed when no relatives are there? Maybe she is a patient, she can be given to some sort of a Pramasamazam or a destitute home where she can get some food and some sort of a little amount of nursing care, instead of keeping it in a high standard hospital and wasting the energies of our staff, nurses, doctors, and all this. Kindly think over it.
Yes. Hello.
Yeah,
Yeah.
yes.
This, yeah, exactly. This is what I was saying. My first part, that how far we can go in the treatment of destitutes regarding the government medical college hospital with the limited, like we have high pressure on the beds, and we are looking for, like she's already there for now 1.5 months in the hospital. We are trying to find out if we can give to somebody. She needs 100% care. She cannot eat herself. She just swallows if she has been fed. Secondly, the family had been traced on the second day itself. The police had gone to them. They were brought, but they said that we can't do anything, and they disappeared again. So off and on, the sister tells that the son comes in sometimes, but he says that I can't do much because apparently she has a social history of the son is from the first marriage, from where she had walked out, come to the second husband who had been taking care of her, and now he has disappeared. He is just disowned. So practically there's nobody to take care of her. And as far as I did not mean to blame doctors. Yes, she has not followed commands, but from all the records that was, I think the son who had left her finally, at least, you know, humane wise, he left all the records there because he probably thought that government hospital people will do something for her. So when I was going through the records, all the discharge slips had a command of follow-up command for 7 days or 10 days in the big hospitals, but nowhere I feel had she been advised that she's taking acetron. So only thing, she may not go anywhere, just get an INR done in a couple of months, and if the value was more than 2 to just report. I mean, this is what was my interpretation. I don't know whether she was told or not told. So, you know, follow-up was always advised. So I feel that it is a bit of poor communication and less talking to the patient, because I'm sure if she has spent so much, she is not so ill-educated that she cannot understand that this one test is so vital for her. So that is where I thought that our communication skills are definitely the significance of telling them one vital point. Like we asked them to come for follow-up, but what is important was probably not told to her. And now we are trying to look for places in Dehradun who are going to take her up, but that has not happened. Ultimately, the MS has decided that we can't do anything more for her. We hand over to the police, and then she will probably be sent to Nari Niketan. But what they will do there, God only, because she needs 100% hygiene care, bladder, bowel, feeding, turning also, because she can't turn in bed herself. She just, seems to understand from her eyes this thing. She expresses pain on IV injection, like the cannula was there earlier. So it's not that she's just written off. So the palliative care, from this point of view, all her functions, all her investigations are normal so far. But as soon as the hygiene goes down, the UTI will begin, the feeding will go down, and that will be the finals.
Yeah. Dr. Bini?
See, the very fact that she went to corporate hospitals in the beginning and ultimately ended up in a government hospital, it seems itself shows that the patient cannot afford the treatment. So that is why she has been neglected and dumped in the general hospital. So we need to understand that our constitution, India is a welfare state, and it is everybody's right to be looked after, at least in the government sector. So as per, Article 21, I think, right to life, we cannot deny anybody the right to life and a dignified death. So as far as that is concerned, where else would we run if it's not a government hospital? That is one thing. So I think this is where social workers or hospitals should have a team which will represent the cause of such destitutes, so that we can render, the state has to look after, just like we would look after people in our prisons and everywhere. If you're a destitute, somebody has to look after us.
So far, her treatment has been done from like we doctors in our hospital have created a sort of destitute fund, and from there only, because all the medicines that she needed and everything that she needed intra-op is not available in the government hospital. So enough has been spent on her by donations from the doctors, from the destitute fund. But how far can limited resource system can go? Because officially the government hospital does not have any destitute fund. Officially, they may not discharge her, but then there's a very hard pressure on the beds, especially in the neurosurgical wards. So they are trying to find out any organization who's willing to take her. Otherwise, the last step is that because she's abandoned in the hospital, the police will have to be involved again. And if they can force, but probably the husband has already locked the house where the address and gone somewhere. The son comes off and on at times when he'll not be noticed. And he told the nurse that I am just coming on humanitarian grounds. I have no attachment to her. She had abandoned me when I was a small baby. So you can't say much to him. So.
Doctor,
Madam,
yes, sir.
Madam, there must be the social welfare department, local
Yes.
panchayati municipality, and there must be there some other social organizations like as we have Alliance International or Rotary International. They have, in case they have destitute houses, they will be able to take care of, but they will not be able to give her top class medical treatment and experts advice because probably she will not get benefit more by it. And in case of nobody comes, we can look after rituals also. After death, we can or in case we have an option in our Brahma Samajam, our patients who get admitted, we ask them whether they're willing to donate their eye corneas or willing to donate their bodies. Or their relatives come and take their bodies after death in case death is essential. Still, we have some SC, ST, social welfare hostels, and some other people. Government is financing many of these institutions. Of course, my institute is not, but it's a nearby case for about 100 kilometers. I would have taken her to my hospital, my Samajam, where we, as a doctors of a team of 10 members, we can give minimal amount of care until her death. There should be some place.
Right. Yeah, we are trying to find places. Maybe Ganga Prem Hospice and Rishikesh may oblige, but that's a private center. But we are going to communicate with them. But it is a sad story, and her palliative care now is only nursing, which I feel most of the post-head injury patients, they have their other systems normal, and they just need some nursing care and feeding care for as long as they live. With a little of positive approach, which she was getting in ICU when nurses were one-to-one. So she used to smile also. I mean, her eyes, from eyes she could make out if they offer a toffee to her, she'll be, opening mouth spontaneously. So it's not that she doesn't understand. She can't turn, she can't sit, she doesn't tell about her bowel and this thing, but from her eyes you can make out that she is following what you are trying to say.
Okay.
Yeah.
Thank you.
We should go further. Yes, the psychosocial aspect is an important problem in this.
Pankaj, do you have anything more to add on this?
Yeah. Yeah, I think this is one of the case that that suggests that how much need we have in neurological patients. Such patients. I feel like there must be a lot of burden on the caregivers. Also, they have taken care of the patients for long years. But at that point of time, then when the patient was like vegetative and they felt, they might have felt like it will be a huge burden, or they may have a burnout. So as a palliative care, we see for the family also. So maybe if in the future, if we get the family members also, maybe we can speak to them, or we can counsel like how we can reduce their distress and the shared caring for the family members. So those family members, if we can by luck, if we get them, maybe helping them also, because they have taken care of the patients for almost around 10 years. that may be, and for the treatment of the destitutes, like Dr. Murthy has told, like there are many institutes for that. When I was working in Tata Memorial, we used to get a lot of such cancer patients. So there are also those social bodies. They used to volunteer for them, and our hospice, because in our hospice we need at least a caregiver. So he used to miss that social workers body used to be the responsible caregivers for those destitutes. So there are some systems, some volunteers or social workers who can help in such conditions. But if we give, in such cases, if we give good communications, not only for for warfarin or for INR, talking about how they are caring or identifying the burnouts, empowering the family members may also help.
Right.
Are there anybody else want to add any more points? Okay. In case of destitutes, we have to give the treatment, and there may not be anybody other than the treating doctor who has to do the needful. Otherwise, the doctor will be found guilty if he has not done his primary duty of caring the patient. So we have to give the acute care for these patients. And in this scenario, could we have prevented this abandonment? We are not sure, but it is something that Dr. Pankaj has already told, that if the burden of the family, if there previously if there were a way to reduce it, maybe because of financial problems or social problems, all these have culminated in abandoning the patient. At first, if there was some involvement, maybe not necessarily palliative care, but from the at least a social worker or somebody from the hospital, if there were a possibility of seeing a social worker, then they could have interacted with family, and they should have done some psychosocial support for this family. So possibly they might understand, or there were some solutions possible at some stages, which could have prevented abandoning. And regarding the acetrom part, it's also at doctor's duty to explain to the patient regarding how all the medications work and what is the importance of follow-up. So if something like acetrom is given, it's our duty to explain that it is very important to check the INR. So there may be some problem with the patient part also. Even if you explain it repeatedly, many patients don't do it, maybe because of many things. They don't have money, their social circumstances are very difficult. All those are practical problems. So here, what caused the problem, we don't know.
Now there's no way to know.
Yeah. So, but you have actually indicated the social aspects of palliative care, and if you take the psychosocial problems of the patient, it is very difficult to manage. So we need actually the support from the community, and without them, it will be unable to manage. And the resources required for managing the psychosocial problems, it's very difficult without them, if you don't have resources.
Yes.
So, thank you for presenting this patient story and highlighting the importance of social aspects. So, thank you, Dr. Pankaj, for taking a very important session on palliative care. And thank you, Dr. Hema, and thank you all the others for joining us.
Thank you all. Thank you, sir. So we can see you on next Wednesday.